Hello, my name is Abhinav Sharma, and I'm from the Duke Clinical Research Institute. I have the pleasure today of speaking with Dr. Michael Farkouh from the Peter Monk Cardiac Center at the University of Toronto. Thank you very much for being here today.
Thank you, Abhinav. Great to be here.
So can you tell us a little bit about what led to your research work that you presented yesterday at the AHA?
Yeah, so what we did is we took the three major peer-reviewed federal trials of addressing coronary revascularization in diabetics, Courage, Berry2D, and Freedom, and we used patient-level data to do a pooled analysis, looking at important subgroups like double and triple vessel disease, those with low ejection fraction, and those with proximal LAD disease, and presented it. So it was an exciting day.
It was definitely very interesting information. Would you mind telling us the top points with regards to the data that you presented?
Yeah, well, what we found is we did two analyses. One is we compared randomized patients within these cohorts of optimal medical therapy versus optimal medical therapy with coronary revascularization. And in that, we really didn't add much to the individual trials. So the two trials that had such patients were Courage and Berry2D. And these, again, are all diabetic patients. In Courage, we took the diabetic subset. In Berry2D, they were all diabetes patients. And in that analysis, really, we confirmed that across the board, whether it's for any of these important subgroups, angiographic subgroups, ejection fraction subgroups, that really there's really no difference between optimal medical therapy alone and optimal medical therapy with coronary revascularization, suggesting that optimal medical therapy may be a viable option in patients who do not require an angina relief necessary or that comes with coronary revascularization, but rather for survival and survival free of MI and stroke, the outcomes were quite comparable. The second part of the analysis involved PCI versus CABG, both with optimal medical therapy. These are largely the Freedom patients and the patients within Berry2D that were in the CABG strata. And in that analysis, we were able to show that not only was there a benefit in triple vessel disease, which was largely the Freedom population, but also in double vessel disease, in patients with normal ejection fraction, and also in patients with or without proximal LAD. So really expanded out the indication for CABG in these important trials. The one thing that we weren't able to show, we had a strong trend even towards single vessel disease benefiting from bypass surgery, but that was not statistically significant given our correction for multiple looks. So our p-value for significance is 0.003, which is quite rigorous.
And how will this change your clinical practice from a day-to-day point of view?
You know, we've always thought that multi-vessel disease it should be treated with bypass if the patient has a favorable risk-benefit equation. And of course, the risk is stroke. So there's a doubling of stroke early on in the first 30 days. That's when most of the excess strokes occur. So that if I have a patient who's younger, that means under 75, patient that has a favorable risk-benefit profile, I would go for bypass first. What this does is kind of reassures me that my double vessel patients, particularly those with LAD disease, would benefit also from bypass. And I'm even concerned about those with isolated LAD disease, whether in the long term they might benefit from a minimally invasive CABG procedure compared to throwing a stent in.
And what does the future hold in terms of research in this particular field?
Well, I think the next step are to rescue some other important subgroups, those with chronic kidney disease, for which we don't really know what the results will be for PCI versus CABG, and those with GFR less than 60 and less than 30 is even a more important subgroup. That group also has the added risk of renal dysfunction from dye and so on, so that we really want to look at that, and even the benefit of a triple analysis in that group of optimal medical therapy versus PCI versus bypass. The other important groups, I think that we want to start expanding this out to those with pre-diabetes and those at risk for diabetes, because now we have an important other endpoint, which is not only the MACE endpoint, but the endpoint of heart failure.
Well, thank you very much for your time. We really appreciate your discussing your results today. This is Abhinav Sharma with Dr. Michael Farkouh from the Peter Monk Cardiac Center. And if you want more information, please check out the Duke Fellows blog. Thank you so much for your time.